Hello everybody and welcome to the Tuesday edition of Video Clips. And I'll start with just one announcement. We only have one important announcement, and probably this will be the way it is for most of the next couple weeks. And that is our conference is coming up November 4th through 6th, and you do not want to miss it for a couple of reasons. And the first one is it's our 20th anniversary, and I think staying in business for 20 years and building a great company like this with wonderful people I've gotten to work with, we have a lot to celebrate. We really want you to join us. And so we've planned not only an amazing conference, but an amazing Saturday night party that is part of our conference, and the party's on us. You just show up and eat and dance and toast us at midnight or at 11 o'clock. I don't know if we'll last till midnight because it's kind of a long weekend, but anyway, we will have some fun if you choose to join us. The other reason is we have some amazing speakers that include Neil Barnard from the Physicians Committee for Responsible Medicine, Colin Campbell, the author of China Study and Whole, Rethinking the Science of Nutrition, Dr. Janice Stanger, one of our favorites, who's going to talk about nutrition and pregnancy, Dr. Thomas Seyfried, who wrote a great book called Cancer as a Metabolic Disease. He's going to talk about how cancer can be turned into a chronic condition that people die with instead of. We have, who else is on the roster? Oh, the Marielle von Lanthen's going to talk about diet and gastroesophageal reflux. And the list goes on, but you don't, and we're going to screen Food Choices. If you haven't seen the movie Food Choices and you're not watching it on cable TV or iTunes, you can come and watch a screening, and the producer is going to be here, so you'll get a chance to meet him too. So I could go on and on. The food's amazing, the people are amazing, it's our 20th anniversary. Be here. If you want to register, you can go online to our website. There's a little video about the conference that I made a few weeks ago, and also registration forms and that kind of thing. All right, today I want to talk about death from chemotherapy. How's that for a dreadful subject? But it's really one we need to talk about. According to new research, chemotherapy is killing up to 50% of patients in some hospitals in the UK. I think that's probably going on here in the United States too, but this particular research comes out of the United Kingdom. The study was conducted by Public Health England and Cancer Research UK and looked at the mortality rates of cancer patients 30 days after they started chemotherapy for breast and lung cancer. The goal was to look at treatment-related death rates in order to determine how patient care could be improved. Now, this is very important since what is called systemic anti-cancer therapy, that's really chemotherapy, has increased significantly during the last several decades, and it's now used routinely for many types of patients with cancer, if not most. Now, most patients think that chemotherapy improves long-term survival because, let's face it, who would sign up for chemotherapy if you didn't think it was going to make a difference? But it's often given even when there is no hope of survival or for just symptom relief. And it does provide symptom relief, and I'm going to come back to that, but there are some problems with this. Patients who die within 30 days of starting treatment don't really get survival odds, as you'll see in a second here, or the benefits of palliative care. Palliative care is making people comfortable during their dying days. Aggressive chemotherapy does not do that. For them, it's only harm. One of the reasons that chemotherapy can't really that causes this harm is that it can't discriminate between healthy and unhealthy cells. The researchers that did this particular study said that infection due to low neutrophil count is the most common reason for chemotherapy-related death in the first 30 days after treatment begins. And so the problem is if you take patients who are terminal and you give them treatment that can't save them, nothing good can come out of this. They're not going to be comfortable. There's nothing comfortable about chemotherapy if you've ever had it or you know somebody who's had it. All you're doing is making their life worse. You're not improving anything. Now, the study was pretty massive. It included all women with breast cancer and all men and women with lung cancer in England who were 24 years of age or older and had started a cycle of chemotherapy in 2014. There were over 23,000 breast cancer patients and over 9,600 non-small cell lung cancer patients. This was actually the first time that 30-day mortality for chemotherapy had ever been looked at for a cohort this large, being treated through the National Health Service in England. Death within 30 days of starting treatment is an indication that the medication is the cause of death rather than the treatment, or rather than the cancer itself. For purposes of this study, chemotherapy, or SACT, was defined as any chemotherapy, anti-cancer therapy such as monoclonal antibodies, or target biological treatment. Mortality was higher with increasing age for patients with breast and lung cancer treated with intent to cure. Interestingly enough, 30-day mortality was significantly higher for patients getting their first treatment versus those who had been previously treated and for patients who were sicker overall. And so the bad part about this is the sicker the person is, the less likely they are to survive, and the more sick that person's going to become as a result of toxic therapy that can't possibly save them. In some hospitals, the death rate was actually pretty low, like 8.4% for lung cancer patients and 2.4% for breast cancer patients, but in others, the death rate was over 50%. At one teaching hospital, the 30-day mortality rate was 28% for palliative chemotherapy for lung cancer. Palliative care for breast cancer, 20% mortality rate. Sometimes palliative care, which is administered when patients are terminal, includes chemotherapy, which is supposed to alleviate symptoms, and in these cases, the treatment seemed to kill the patients prematurely while relieving their symptoms, and that's sometimes I don't want to call it the odd thing, but the ridiculous thing about the treatments that we provide is we make people feel better while we kill them sooner. I don't think that's the objective of healthcare. Now, some hospitals seem to have significantly lower 30-day mortality rates, but the researchers cautioned that that might not mean that anything good is going on. They hypothesized that one of the reasons might be that they're just a little bit more selective about who they're giving treatment to because they don't want to make their death rates look bad. And a lot of that type of thing goes on in hospitals and medical institutions around the United States. I mean, one of the reasons why the push is so huge for flu shots, for example, not anywhere near as serious as chemotherapy, is that hospitals get rated and they get reimbursed, and there are all kinds of incentives tied to what percentage of their healthcare staff they get to have a flu shot. So really bad incentivizing. We should be incentivizing healthcare only for better result for patients. That's the only thing that should make a difference, in my opinion. Several factors affected the risk of mortality, including whether the treatment was curative or palliative, age of the patient, whether or not the patient had received previous treatment, and disease stage. All hospitals at the end of this got a report from the researchers with an encouraging recommendation. You should be looking into your practices to see if you can do better. One of the strengths of the study was the 30-day benchmark. Death certificates almost always list the cause of death as the disease the person had and not even consider the thought that the treatment might have been the cause of death. This is one of the reasons why consumers continue to be misinformed about the benefits and risks of treatment. And by the way, the same thing is true in the United States. An article that I covered not too long ago in this series of videos clips talked about if you look at the data, the third leading cause of death here in the United States is medical care. Now, the Centers for Disease Control doesn't even have it in the top 10, and one of the reasons is because the death certificates, which is where the data come from, don't even say, died of treatment. It's always died of heart disease or died of cancer or died of whatever the disease was the person had. One of the limitations of the study that the researchers pointed out was the fact that there was no control group who didn't get treatment, but that is never going to happen during our lifetime, and I'll tell you why. With the community standard of treatment for a lot of these patients is chemotherapy. And it is considered unethical to withhold treatment, even if it's mostly harmful, doesn't help, from patients. It's considered unethical. You can't do a trial where even the patients would be asked, do you want to volunteer to do this? So unfortunately, we don't get really good comparison studies because of the strange way that we look at benefits and risks to patients. The researchers found that 30-day mortality was higher than previously reported in clinical trials, and this happens all the time. And they hypothesized, and they're right about this, it was probably due to inclusion criteria in the trials. It's an ongoing issue. Drug companies select what we call perfect patients for their trials. They have fewer risk factors, they're often not taking other medications, they don't have other diseases. In fact, the researchers wrote, this might be because clinical trials typically recruit a fitter cohort of patients with a lower disease burden and better performance status than the overall patient population receiving treatment to clearly determine the effects of the interventions under investigation. So I've always thought that the big clinical trial for almost anything, ranging from statin drugs to, in this case, chemotherapy, is really done in the general public when real people who have real illnesses and bad state of health start taking these drugs, and that's when the adverse events start being reported to the FDA. While researchers Dr. Jem Rashbash and a couple of her colleagues defended chemotherapy, saying that it improves survival rates, she acknowledged that the drugs have serious side effects, and one of those side effects the study shows is death. And she says it's challenging to determine which patient should be treated aggressively. I don't think it's challenging at all, and I don't think the doctor should be determining it. I think the doctor should be putting information in front of the patient and letting the patient decide. So this woman, in my opinion, needs to know about informed medical decision making. Who is she to decide who should be treated aggressively? Why not let the patient decide? Researcher Dr. David Dodwell said, quote, "I think it's important to make patients aware that there are potentially life-threatening downsides to chemotherapy, and doctors should be more careful about who they treat with it." Amen to that. I mean, again, patients deserve to be informed. I hear it all the time in this office. If I knew then what I knew now, I never would have agreed to, and you can fill in the blank with whatever treatment, drug, whatever these people did. All right, that's all for today. As usual, pass this on to anybody who you think might enjoy watching it, and I'll be back to you on Thursday with more news.